So on behalf of LMSK, once again, feel welcome to this webinar of 22nd of August, the year 2025. This is an interesting topic that we are going to handle today, and it's worth noting that this webinar is CAML-TTB accredited and will attract 3 CPD points. And so it's also, once again, very important to note that this webinar will report it for you. And so what we just need and what we just request from you is that your details to be clear, to be correct, so that we don't experience any delay or any bouncing CPD points while we'll be uploading them. And so once again, feel welcome to today's webinar. I'd like just to make some few announcements, and then I'll usher in our presenter who is already in. So once again, I would like to remind everyone that this webinar is live streamed on YouTube, and this is for reference purposes only. When you'd like to come back and refer to something that was explained, something that was, the entire webinar, the entire presentation, you just check on our YouTube channel. So it's good to subscribe to our YouTube channel and watch these sessions for reference purposes. We don't award any CPD points when you watched the presentation on YouTube. So ensure that you take note of that. Secondly, timing is of essence, and so there's a policy of 60% attendance. The duration that you take to attend to this presentation, ensure that you take at least 60% of the total duration that is designated for this webinar. This is one of the eligibility criteria to award you the CPD points, as I've just talked about. On behalf of LMSK, once again, feel welcome for today's presentation. So today's presentation, we are privileged to have actually an expert by the name Cosmas Baraza. I'd just like to highlight some of the qualifications of our presenter today. I'll start with his academics details. So Mr. Cosmas Baraza has a degree in medical laboratory sciences and also a Master of Public Health. In fact, currently is pursuing another master's degree in medical lab sciences, but specializing in cytopathology major and histopathology minor. Mr. Cosmas Baraza has a vast clinical research experience, majorly in blood safety, quality systems, and actually right now is currently working on the cytopathology of ascites. He also facilitates voluntary student mentorship and CMEs. So with this, Mr. Cosmas Baraza has a vast experience of 8 years. He has worked in various labs ranging from class B to class F, and is involved in quality management practice for laboratories, that is ISO 151 89 2022. And also the ISO, the quality management practice for the hospital, which is the ISO 9001 stroke KQMH stroke safe care. So Mr. Cosmas Baraza has been a leader in healthcare sector in different capacities, and he's been a departmental head, IPC champion, quality manager, AMR champion, and currently Mr. Cosmas Baraza is a laboratory manager at Hopkins Crescent Hospital, which is in Bungoma. So with this, we are quite excited to have Mr. Cosmas Baraza today to take us through today's presentation, which is on clinical and diagnostic approaches to tumor markers. So this is an exciting session, and I would encourage all of us to be keen. And if any of us will be having any question, ensure that you just type it at the Q&A section, and we will ensure that Mr. Cosmas Baraza and even some of the members who are on board would be able to respond to all of your concerns accordingly. Thank you very much. To this end, I'd like to welcome our presenter who is here with us. I hope you can hear me. Mr. Cosmas Baraza, if you can hear me, kindly check the mantle and proceed. Karibu sana, Mr. Cosmas.
Okay, good afternoon. Good afternoon, everyone. Just to start off, maybe to confirm if you can hear me.
Yes, I can hear you sound and clear. And with that, all of us can hear you well. Please proceed.
All right. All right. Thank you so much, George, for the elaborate introduction. I believe that I may not be able to go back there. It's a pleasure once again being back to go through one exciting topic so that we can learn, relearn, and also utilize our knowledge as we serve the patients that we are seeing. Now, just before we start the topic, I just wanted us to have the general information on cancer in mind. Now that we have been having Cancer Celebration Month, Breast Cancer Days, the prevalence of cancer is there, cervical cancer, people are having colorectal cancer, lung cancer, and all the other types of tumors that might be encountered in the community. And I just want us to have that open-minded approach to this particular discussion so that we may learn one or two things and we may be a pillar to the people that we are actually living amongst, that's in the community, if they may need a service of that nature regarding cancer diagnostics, or they may need an information to help them monitor their progression with treatment. I believe that this is the webinar that's going to help us answer those questions and also look at the best modalities of how we can be able to test them and evaluate them in the lab as we progressively monitor the treatment that these patients are undergoing. So the topic there is clinical and diagnostic approaches to tumor markers. And those are my details. Once right away to the objectives of this presentation, we would like to cover the following. We would like to define the tumor markers and their ideal features. These markers that are going to help us know whether a person has cancer or they don't. Understand clinical indications for tumor markers. Then explain diagnostic relevance of tumor markers. We're also going to describe the most commonly encountered tumor markers. We can't highlight the entire list. There are so many. And then expound on diagnostic modalities for the tumor markers that we have actually highlighted. So on the first objective, we want to define tumor markers. And we know that these are substances that are actually produced by those tumor cells or cancers themselves, or they could be produced by the body in response to the presence of a cancer in the body. So they could be metabolites, things that are secreted into circulation and maybe available in body fluids, such as blood, and other fluids, the tissue fluids, um, and this can be able to help us indicate the severity of the cancer, can be able to help inform the prognosis. Prognosis is whether cancer is progressing well, or someone is responding to treatment well, or they are not responding well. So that's the prognosis. If someone has poor prognosis, that means that their treatment is not working very well, or their cancer has progressed so much. If they have good prognosis, that means that their cancer is not so severe and they are responding well to treatment. Then inform the treatment choices, especially now at the age of molecular medicine and those targeted treatments. I think molecular oncology is a field that is now being applied so much so that the clinicians and the oncologists can be able to target the molecular markers against which their treatments are going to work. So, tumor markers include the cell surface antigens. They can also include cytoplasmic proteins, uh, enzymes, hormones, oncofetal antigens, receptors, oncogenes, and their products. So they could be any of those items that I've highlighted there. And guys have done so many researches, and they have come up with so many tumor markers in those categories, and we're going to look at some of them. Now, these markers can either be produced by tumor cells or the body in response to those tumor cells. So, as I've highlighted as well, we know that the cancer cells are in themselves abnormal. They'll be able to produce abnormal proteins, abnormal genes, abnormal molecules that could be, signaling, or they could be, tested to signal the presence of a cancer, or the body itself can be able to produce other materials that are trying maybe to fight off the cancer, and or inflammatory markers even. They can be able to indicate a chronic inflammation that's underway, which is most probably cancer, although there are other chronic inflammatory processes that could be encountered, but the most common ones will be highlighted well when we are looking at the individual tumor markers later in the presentation. Now, we'd also like to highlight and say that the cancer is caused mainly by proto-oncogenes. These are harmless. In fact, they are good, but if they undergo the gain of function mutations, and they can be able to change into oncogenes, which are now problematic, then they can be caused by tumor suppressor genes, which can also be failing to suppress the cell division process, and then leading to uncontrolled cell division, which is just uncontrolled proliferation of cells that will now lead to growth. Could be benign, could be malignant, but they are growth anyway. And they can also include DNA repair genes. So tumor markers can be circulating, as I had mentioned before, in serum or in blood, or they could be in body fluids, and they can be tested in those particular, substances or materials, or they could also be integral components of the cell. This could be maybe the cell membrane, the cytoplasm, or the nucleus. Tumor markers could be anywhere in those cells. Now, the diagnostic modalities will now mean that if we are looking at the serum, then we are going to look at diagnostic modalities for serum. We're looking at body fluids. We're going to look at the diagnostic modalities for fluids, which could mostly include urine. Yeah, tumor markers can be, analyzed in urine, and maybe ascitic fluid. That's where I've seen common tumor markers being analyzed. And then integral components now will involve looking at the tissues themselves or individual cells. Now, this is for those guys who are maybe working in histopathology and those kinds of setup in cytology. Now, the approach is both is going to look at the tumor markers from an entirety of thinking, so that when you get a kind of an inquiry from somebody, it could be within the clinical team, it could be within your colleagues, it could be in the community there now, and you're the only medic who is there. You can be able to, have a clue and explain this concepts in a way that you can be able to understand, and can also make someone who is a layman to understand these particular things like that. Now, circulating tumor markers could include such things as, of course, in the usual non-specific, because they are not produced by a single organ. They are always also present, but in less amounts. But we can be able to associate some few cancer antigens or cancer markers to specific organs, although they are not specific, but with the clinical and radiological correlation, you can be able now to point out that, oh, this CEA could be elevated in this particular cancer. Now, they include things such as CEA, which is carcinoembryonic antigen, alpha fetoprotein, then CA19-9, CA15-3, and others, which can be elevated in a variety of affected organs. Now, these ones can be measured by serum or fluid immunoassays, such as chemiluminescence. We have those equipments, fluorescence immunoassays, or radioimmunoassay modalities. So those immunoassays are there, and they are the diagnostic modalities that we have for the circulating tumor markers. Now, as we go on to the integral, what I'm calling integral tumor markers, these are components of the individual cells, and they are parts of the affected cell. They are molecules or components that are only detected in the primary cell containing the tumor. They could be surface receptors, as I had mentioned before, where the specific surface receptors are elevated in specific conditions. This one is especially important in hematological cancers, where you find some cluster of differentiation of CD markers elevated in different kinds of hematological malignancies. When you're talking about acute, maybe lymphoblastic leukemia, you can type via flow cytometry and tell whether this is a T or a B lymphoblastic leukemia, like that. So those are the cell markers, cell surface markers that can be able to tell you that this is an individual tumor marker, an individual tumor cancer of this particular nature, and you can be able to categorize it like that. It could be cytoplasmic components, and they could be nuclear components. Cytoplasmic components could be proteins that have been, secreted in the nucleus, and now they can be detected in the cytoplasm. And modalities such as immunohistochemistry are applied here, where there are several proteins that could be, identified in the cytoplasm through staining. There are other molecules that could be identified in the nucleus through staining. So different staining for different uh, oncogenes or tumor markers could be found in those specific regions in different kinds of cancers. So if you're interested in a molecule that could be found in the cytoplasm, then you're going to do your staining, but the focus of examination will be in the cytoplasm, like that. And the SAW is applied to the nuclear component. Now, they are also the more specific as compared to the circulating markers. They are more targeted and play a critical role in oncopathology. as well as molecular determination of best treatment to be used. An example here, a very good example, is the ER and PR receptor positive, maybe breast cancers, which respond very well to a particular treatment. When they are negative, then the treatment becomes very problematic, all right? And then the prognosis becomes very poor for those particular individuals. So we can have these kinds of tumor markers helping us to target treatments for these patients to get well. They have superior applications in diagnosis, prognosis, and treatment selection for oncology patients because they're actually looking at where they're looking at the primary cell where the abnormality is. And it is important that we now will be able to realize that this is not something that's maybe produced elsewhere in a healthy cell, because these are just going to be integral to the cell that is actually containing the tumor itself. Now, they include HER2, ER, PR, with 2CK, that's CK7, class of differentiation, and then KRAS genes, BRCA, etc. There's so many tumor markers, those ones over there. And there are modalities to stain them immunohistochemically, and then you can be able to look at them under the microscope and you can say that this one is a positive for this particular marker. And the positivity is this way, single plus or whichever the grade. And then it can help the clinicians like that. Now, of course, diagnostic approaches to this include molecular level, and they are FISH. FISH is fluorescence in situ hybridization, IHC, immunohistochemistry, ICC, which is immunocytochemistry, and next generation sequencing. This is the whole genome sequencing of the particular individual tumor product to determine the kind of tumor it is, or maybe PCR, simple polymerase chain reactions. So those are diagnostic modalities for integral tumor markers, and we've already seen the modalities for circulating tumor markers like that. Now, we shall be able to highlight some of the features of tumor markers. Now, I should be able to say that for the circulating tumor markers, only PSA or the prostate specific antigen has been determined to be clinically and epidemiologically applicable to the population, that is, because it's very specific to the prostate cancer. Or if it's not prostate cancer, and then it is the benign prostate, the benign prostatic hypertrophy or BPH, which, when elevated, of course, will now create more questions for these guys to go for further analysis. That's the only tumor marker that has been, given the green light for population-based screening for the rapid tests or for general screening of the population. Because you will not find another tumor marker that possesses all those ones, especially for the circulating tumor markers, not the integral ones. Now, we are saying that a good tumor marker, a perfect tumor marker, should possess a high positive and negative predictive value. Those guys who have done HTC, I think the algorithm was changed from the 2-tier to 3-tier using these kinds of terms. And I believe that we can be able to understand that the positive predictive values is the ability for this tumor marker to tell the presence of a cancer, which should be high. And then the negative predictive value should also be the ability of the tumor marker to tell the absence of this cancer, which should also be high, so that you don't have false negatives, you don't have false positives, like that. Then the high specificity and high sensitivity. Specificity is the ability to detect the presence. Sensitivity is the ability to detect the absence, which is just translate to high to positive predictive value or the negative predictive value respectively. They should have a long lead time, right? To allow for monitoring of treatment, yeah, so that it is possible to monitor treatment over a period of months, a period of whichever, depending on the tumor markers that are being handled or the kind of cancer that is being handled. Then they should have a shorter half-life that will allow for serial monitoring. Yeah, physicians will want to know how their patients are doing, and a tumor marker can be able to help, should be able to help uh, serially monitor these patients. Now, if the half-life of a tumor marker is 2 weeks, then a monitoring of 2 weekly is good. If a half-life is longer, maybe 1 month or so, that kind of monitoring can also be done so that you're not measuring the quantities of the tumor marker that you measured a while ago, but the one that was there has already been broken down and metabolized, and the new tumor markers, which are indicative of the current status of the patient, are there now, which can now be monitored, measured, and monitored for serial monitoring of these patients who are on different kinds of modalities for treatment. Now, their levels should correlate with the tumor severity, which is self-explained, and they should be inexpensive, very simple, standardized, and automated, uh, and which could be very easy and clearly with clearly defined reference values. It's very difficult to get reference values for tumor markers, by the way, because your control population uh, might be having a subclinical tumor, and you looked at a person empirically. You can include them in the study to determine the reference values, but they are having subclinical tumors. Now you end up having very, very wide ranges of tumor assays just because of the lack of a suitable population, because you can't really tell when you're trying to find those particular reference limits. So a good one should have a clearly defined reference limits, which is not influenced by those other confounding factors. Should be acceptable to subjects undergoing the test. Yeah, should be acceptable because you're going to do it. You're going to do it on somebody. Have and it's have its clinical value validated in a large prospective trial. Prospective is a future-oriented trial or maybe research, which will involve active uh, data collection going into the future, because now you're looking actively to determine the clinical value of this particular tumor marker, not retrospective, which could be influenced by so many other things, because you never know what happened at that particular time in the past. So those are the features of tumor markers, and an ideal tumor marker should have all those. But we will not find a tumor marker that's having uh, 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 all those features, apart from PSA that I had mentioned. So that's why you can see people doing medical camps and they're doing PSA screening in the field. It's allowed. It's acceptable like that, because that one's a specific tumor marker. Now, on classification, tumor markers could be classified differently depending on the materials that are making them. And we have a few classes that I've highlighted here. Mostly this is applied to circulating tumor markers. They could be oncofetal antigens, which is CEA and AFP, present in rapidly growing, tissues, and present in fetal life. Then hormones like beta HCG, catecholamines, and calcitonin. Catecholamines, these are the adrenalines, adrenaline and noradrenaline, and then calcitonin as a hormone. Then glycoproteins, which include PSA, the CS, all those cancer antigens. Then we have metabolites like the vanillin mandelic acid, which is a tumor marker, mostly analyzed in urine. Then the 5-hydroxindole acetic acid, which are metabolites from the tumor itself. Then the tumor-associated antigens, viral antigens. Um, Viral antigens are things such as maybe they are normally associated with several tumors. Like, for example, there is Kaposi sarcoma that's associated with the type of herpes simplex virus. And then there is cervical carcinoma that is associated with human papilloma virus. So if those viral antigens are present, they are also tumor markers. Then oncogenes and oncogene products, and then enzymes, acute phase proteins, yeah, and then inflammatory markers like ESR, then ultrastructural components like vimentin and desmin. These ones like microfilaments, the ones that are present in the cytoplasma, they are increased in those uh, chronic conditions. So these are associated with different cancers. They are tumor-associated antigens. And for you to identify the individual tumors, you'll have to do other ancillary tests so that now you can determine that this is a particular tumor that you're dealing with. But those are basically the classes of tumor markers that you may expect to find. Now, the same is highlighted here with the examples, of course. Now, enzymes include things such as alkaline phosphatase for bone osteosarcomas, then prostate specific antigen for prostate, and then prostatic acid phosphatase also for prostate. But largely right now, the PSA is being used. Then hormones such as ACTH, calcitonin, growth factor, growth hormones, and then the HCG, even prolactin. These are tumor markers. Now, proteins such as immunoglobulins, beta 2 microglobulin, C peptide, and ferritin. These proteins are elevated in different tumors. Immunoglobulins in those tumors that are leading to high immunoglobulins, mainly the lymphocytic issues. Could be more plasma cells secreting many immunoglobulins in things such as multiple myeloma. The same as beta 2 microglobulin in multiple myeloma. C peptide in those insulinomas. Yeah, there are cancers that are secreting a lot of insulin, and then ferritin in a variety of cancers. Then oncofetal of course, alpha-fetal protein for the liver, then the CEA, then there is the squamous cell carcinoma antigen for the liver as well. Then tissue polypeptide antigen also could be present. Then the carbohydrates include epitopes, of course, include things such as CA125 for ovarian, 15.3 for breast, then 19.9 for pancreatic cancers. Receptors, of course, those receptors, ER and PR receptors for breast and other tumors as well. Could be also present in people with ovarian cancer. Now, tumor-related or associated conditions such as this could be elevated in other conditions. That's why very few tumor markers could meet the criteria or could have all those features that we had highlighted. And we see that alpha-fetal protein could be elevated in viral hepatitis, acute liver injuries, then inflammatory bowel disease, and in pregnancy also, because there is a lot of fetal growth. Beta HCG is elevated in testicular failures, marijuana users, smokers, pregnancy, and all those conditions. You see. Then CEA could be elevated in these are non-tumor conditions, but could have those markers elevated. So in your mind, you should be able to have these as differentials. You rule them out, and then now you concentrate that this is now a true case of a tumor. CA could be elevated in smokers, also inflammatory bowel disease, hepatitis, cirrhosis, pancreatitis, and gastritis. C125, although it's good for ovarian cancer, but it's also elevated in peritoneal irritation, endometriosis, pelvic inflammatory disease, hepatitis, and pregnancy. Endometriosis is actually the growth of endometrium elsewhere, apart from the uterus, where it's supposed to be. Then PAP and PSA could be present in prostatitis. Just an inflammation. You take a PSA, it's elevated. Then the benign prostatic hyperplasia, all right? The BPH also, which is not cancerous, it's just benign. Now, on clinical indications for tumor markers, that the reason why someone could think of doing tumor markers. They could include things such as prognostication of the patient to see whether they're doing well or they are not, whether they are getting better or they are not getting better to the treatment that you're giving them. Could be radiotherapy, could be chemotherapy, or could be after surgery, maybe radical removal of the uterus, or removal of the prostate for people with prostatic cancer and everything like that. Monitoring treatment could also be for diagnosis in conjunction with other tests or other diagnostic modalities, including clinical history, physical exam, and all those, and imaging. Could also include precision and determining personalized medicine. Now that we are in the era of molecular medicine, there are people who are who can be able to determine a regime that's specifically targeted for an individual with a specific genetic makeup and a genetic constitution of the cancer that they are having. So advanced treatment are now personalized and they are now molecular in nature. Tumor markers can also be applied in clinical trials and treatment research. For those people who have difficult to treat tumors or tumors which have no current guideline for treatment, they may now enroll in a clinical trial and they may get better treatment from there. Yeah, there are such kinds of institutions in Kenya which are doing clinical trials in oncology. Now, screening for tumors, especially in large population, and PSA qualifies for this. And then monitoring remission or recurrence of tumors. So any of those could be a clinical indication for the tumor markers to be done. And when they come to us, now for the actual test, we should know that as you release this report is going to answer any of those questions. So we make sure that we're also releasing a very good report for someone to go and rely on. Yeah, they can also go and rely on it to maybe adjust treatments, adjust protocols, and everything like that. So what we do also matters very much as we take it outside the lab like that. I just wanted to show this diagram here, where there's an interplay between different stages of clinical management and the application of tumor markers. So the doctor will be able to suspect malignancy, or maybe this of histologically confirmed malignancy, of course, after the sample has been analyzed histologically. And then you measure the baseline tumor markers with the quantities. Of course, this should be quantitative, so that now subsequently you're going to measure to look at the quantities of the tumor marker. if it was +4 for those immunohistochemistries, then is it going down or is it going up subsequently, or even the circulating tumors? If it was 5,000 at the baseline, is it going down or is it not going down like that? The intervention, which is usually surgery, chemotherapy, radiotherapy, or both, or all of them together. Yeah. So they can interact like that. As you can see, those small circles in between there, these interventions could interact. So the patient can have the best outcome possible after the tumor has been determined. Then prognosis and tumor staging. Now that's where we can have the raising tumor markers, which will mean that there is need for frequent tumor marker measurement. Then failing tumors, which means that the tumor is doing well, responding to treatment. And then we have to monitor the tumor markers at an increasing time intervals. We may not need to do it, more frequently like that. So basically, when we're doing the diagnostics in the lab, we also think about these kinds of things so that we may not be isolated, because we are part of a multidisciplinary team that's handling these cancer patients. Yeah. Like that. Now, the relevance, diagnostic relevance for tumor markers include, of course, they will help in the determination of cancer. They will help in the determination of how aggressive the cancer is. They will help to predict response to treatment, which could be radiotherapy, could be chemotherapy or surgical intervention, or both radio and chemotherapy, or could be whichever the modality that has been used. Then help track recurrence of the tumors. Then help in early diagnosis, which is key. Early diagnosis is very, very key for these particular cases. And an example here would be the use of viral oncogenes such as HPV in cervical cancer screening. Yeah. So it's very good in identifying those cases that are having very, very minimal lesions, which could be able to correct themselves, or they could be corrected using other interventions, and these ladies could be able to come back to healthy lifestyle once again. Another relevance is that they can assist in screening and prevalence determination of cancer. Now, if this is in the population, and this prevalence, of course, leads to epidemiological data that could be piled up and then show the cancer burden of a particular country, and then maybe form a baseline from which guys can be able to develop guidelines depending on the burden, and target specific cancers depending on how much they are. So after screening, you can be able to tell that this is the most troublesome cancer in Kenya, and then intervention should be able to be targeted there, using different studies like that. They can help guide treatment choices. So those are some of the importance of those tumor markers. Now, I'm going to mention very briefly on common tumor markers because we've already highlighted them. And people approach this from different perspectives. Some approach them from individual cancer markers and explain downwards. But I'm approaching it from organ perspective, then highlighting the cancer markers in that order that could be important in different cancers of different organs. Like, for example, for breast cancer, we have CA15-3, which is usually elevated, and these others. For those guys who are working in histology, I believe that they are staining those cases that they're presenting for examination by the pathologist. And then lung cancer, which is primarily CEA, or the carcinoembryonic antigen. This one is specifically helping in the diagnosis of the non-small cell lung cancer, or NSCLC. Then the neuron specific inoles, which is specifically for a small cell lung cancer. Then cytokeratin, of course, also for NSCLC. And then the the squamous cell cancer, the SCC, and others, which are specific for different cancers of the lung, like that. So these markers can be able to help us identify the different kinds of cancer that a person has in those particular organs. And then liver, which is mainly alpha fetoprotein, right? And then the stomach, which is I've highlighted from the most relevant tumor marker going downwards. So the most relevant tumor marker in stomach cancer is CEA, followed by CA19-9, and then CA72-4. Then pancreatic cancer, the most relevant one is CA19-9, and that would include alpha fetoprotein and CEA. Of course, now this one you keep in mind with other differentials. Then colorectal cancers, we have CEA, and others are like those ones, because CA19-9 can also occur in colorectal cancers, even CA15-3. And then fecal occult blood. This is something that I need to mention here because it's a screening test for colorectal cancers. For those guys who are having fecal occult blood positive, they have a high likelihood of having colorectal cancers, and this is a very simple test that we normally have in almost every lab. So those guys who are positive could have high probabilities of they show high probabilities of having colorectal cancers, and further testing should be done, maybe imaging or something like that. It's not just to assess maybe iron deficiency or something like that. Mm. Then the prostate, which is PSA, the most relevant one, followed by the PAP. Then testicular, alpha fetoprotein and HCG. Bone, we have the bone specific alkaline phosphatase. Then serum amyloid for pediatric osteosarcomas. These are the tumor markers for the children. For epithelial carcinomas, we have cytokeratins, CK. Then we have the squamous cell cancer antigens, the SCCA. Then the epithelial membrane antigen, or the EMA, which are in different epithelial carcinomas. You may need to assess those particular tumor markers. Hematological, we have beta 2 microglobulin in multiple myeloma. We have BCR-ABL, which is for chronic myeloid leukemia mostly, and this one is a gain of function mutation, which otherwise a healthy individual with some kind of translocations and everything, person develops the CML. Then JAK2 mutations for guys who are having, those high cell counts, yeah. Those high cell count in hematological analysis, we may be able to assess them like that, and then using the cluster of differentiation like that. Then germ cell tumors include alpha fetoprotein, then HCG with LDH. Germ cells, I think we understand what that is. Then the renal cell carcinoma, we have vimentin, CD10, CK7, and CD117. Then adrenal, those tumors of the adrenal gland or the suprarenal gland, we have pheochromocytoma, which are, examples include the metanephrines, those are the markers used, and norepinephrine. Those are the different markers that are used for pheochromocytoma and VMN and the rest. Bladder, we have the bladder tumor antigen, the nuclear matrix protein 22. Ovarian, we have CA125, and the VEGF, the epidermal growth factors. Then we have the uterine, we have CA125. then the human epididymal protein 4 or HE4. Cervical, we have the high risk HPV, which include HPV 16, the strain number 16 and 18, because there are other high risk, but these ones are the most commonly encountered. Then they act via the early protein E6 and E7. Endocrine, we have chromogranin A, neuron specific kinolase, synaptophysin, and then specific hormones in different endocrine conditions. Then medullary thyroid carcinoma, we have calcitonin, which is produced entirely in the thyroid medulla via the C cells. Now, I wanted to mention something briefly on how BCR-ABL brings around the CML, and there is usually the gain in function mutation where a portion of chromosome 9, the ABL gene, which is the normal chromosome 9 is there indicated. Then there's the ABL gene at the lower tip of the longer arm of this particular chromosome at the tip there. Then that's ABL gene is transferred to chromosome number 22. Then the longer side of the chromosome number 22 is transferred and replaced on the longer arm of chromosome 9. Yeah. After the breakage, you will see that they are joining, and the longer arm of the chromosome 22 has come to chromosome 9, and the shorter that ABL gene on chromosome 9 has gone to chromosome 22. And this one is the Philadelphia chromosome that is now tested for in those ABL, BCR-ABL fusion genes in CML. So this is the mechanism through which it works. And I want us to have the open-mindedness. I'm sure after this, you'll be able now to know that tumor markers are not just the PSA, the CES, and those things that we are doing in the serum, in those maybe routine chemistries, but they are extensive and they are molecular. Even those guys who are in the molecular medicine have their own kind of approach to tumor markers. Now, diagnostic approaches, of course, these are the modalities we use in the lab. We can use the blood or fluids for circulating tumors. We can use the cells and tissues for integral tumor cells through ICC, then tissues through IHC, cells, immunocytochemistry, then tissues, immunohistochemistry, like that. Then there are formal diagnostic criteria and guidelines available, which have been developed by different pathology and laboratory medicine bodies, so that you follow a specific guideline and arrive at a diagnosis, like that. These criteria could range from clinical history, following physical exam, the site of the swelling, malignant, either you're found whether it's malignant or benign, relevant circulating tumors if they're in support of your findings, morphological features of the tumor, you describe it, then the auxiliary testing that could follow that particular tumor. Just like the way we follow some kind of a worksheet in microbiology when you're doing gram stain, physical exam of your sample that you've received. Then you can do a wet prep, you can do a gram stain. Then from that, you can culture on a particular plate. Then you can do biochemicals specific for that particular order. So if you're finding gram positive, you're going the gram positive way. If you're finding gram negative, you're going the gram negative way. The same applies here. You're finding a particular morphology, you're going that way. And you're going to use the auxiliary testing to help you arrive at that particular conclusion. And these are very reproducible, because if you're following a standard way of doing things, then there is no other way of doing that thing. That's the only way. So, and this forms the bulk of work in histopath, cytopath, and hematological workups. And the analytical modalities include cytometry, flow cytometry, cytochemistry, IHC, FISH, NGS, and microarrays, and even the reverse transcriptase polymerase chain reaction, like that. So those are the modalities that are available for those integral tumor markers. Now, immunological detection usually relies on monoclonal antibodies. that specifically bind to epitopes on tumor markers and in turn targeted for identification with uh, dyes for immunohistochemistry. So you just look at the sample, colors developing all over the place because there is an antigen antibody reaction that has happened there, and your dye has been able to pick it up, and you can be able to look at it under the microscope, and you can tell that this one is a positive for this particular tumor marker. You can also use electrophoresis to determine the presence or the absence of tumor markers, especially the spikes that are usually that are usually seen in monoclonal immunoglobulopathies, like in multiple myeloma, where if you do a serum protein electrophoresis, then you'll see an M band, a spike in the M region, and then which can be able to can follow by the immunofixation electrophoresis. So those can be able to answer those particular questions like that. Um, Radioactive tags are applied in radioimmunoassays, and different equipments have this as the background working principle. So if you're having an immunoassay in your lab, you may have to go check which modalities it is using, whether it is radio, whether it's enzyme or chemiluminescent kind of principle. You can be able to check on it, and all those modalities help us detect the presence of tumor markers. Then flow cytometry analyzes the presence and percentage of antibody targeted cells. And these methods are very, 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 very sensitive, and they can detect quantities of tumor markers to the nanogram and picogram ranges. That's 10 power 6 to 10 power 9 grams. Very, very minute concentrations because these are fourth generation immunoassays. Yeah, very, very specific. Just to add on this one, for screening purposes, there is the chromatographic flow, the chromatographic assays for PSA, the one that you normally do in the field. That one can also be added to this particular modality for circulating tumors. Yeah, so that is what I wanted to mention basically for us today, so that we can have a broad approach to tumor markers, and we may have a clue on what actually happens entirely on the tumor markers. And when someone is saying you correlate with the radiology or you look at the imaging, if you found a particular tumor marker, maybe for liver, has been elevated, you can also check on the radiological exams for that liver and see, yeah, there could be physical presence of an enlarged liver or those kinds of things. So I just want us to open our minds up so that we can also be able to contribute positively and proactively in those ward rounds if you're doing them, and those multidisciplinary committees that you may be able to be involved in, not just being in the lab and creating that information. You can also be consumers of the information that you are producing in the lab, as well as taking it back to our communities and empowering them on maybe cancer diagnosis, cancer prevention, cancer management. These are the things that you should have in mind, because you have the scientific basics of the cancer, and you can be able to answer other questions that may be able to relate to cancer and its management like that. So I'll leave you with this table here, that summarizes what we've been talking about: the modalities or the method of testing, the sample of choice, then the clinical utility of those particular tumor markers. As we look at another table, which I'm going to show you. So finally, circulating tumor markers can be measured through immunoassays, radioimmunoassay. This is a summary of it all. And then fluorescence immunoassay, the HPLC, high power liquid chromatography, electrophoresis, as done in most clinical chemistry labs. These provide quantitative levels of specific markers, providing a means through which monitoring is possible. And here, assay linearity should be considered and possible dilutions made to obtain the actual concentration of the analyte under question. this applies beyond the assays linearity or the upper detection limit. I think this is very important. This is very, very important for people who are using equipment with very low upper detection limit. You might want to dilute these samples so that you can find the actual concentration of your tumor marker and help these doctors monitor the treatment very well. Because if you give maybe a value of maybe above 50, then how high above 50 is this particular value? So you might want to do the dilution, and then you can be able to multiply with the factor that you've diluted and then get the actual quantity and release that particular report. Now, for monitoring, a similar platform is preferred for reliability and error minimization. So if someone has done a PSA maybe on minividas, right, which is using a different, a particular principle, and then next time maybe they are doing that one on Integra, or Cobas. So they are using different, diagnostic modalities. You might find that integral errors might be there, yeah. So not giving us the actual quantities of the or the actual values of the tumor markers. So you might want to advise the physicians and the doctors that if they did a particular test on in a particular lab, they might want to use the same platform to ensure that they're getting a reliable data, a reliable result, so that it is reflective, not because of it's not different because of the different modality that has been used, but it is different because of the different treatment that the patient has received. So I believe that that point is clear, and that's what I wanted to mention as I leave you with this table, which you're going to look at it maybe later on at your own time, because the summary of it all. And maybe at this particular point, as you look at the last slide, I would want to maybe take it back to George for any questions or maybe any additions or any queries as might be necessary. So thank you so much for listening in, and thank you so much for your attention and your time. Asante, back to you, George.
Thank you, Cosmas, for the quite elaborate presentation. It was quite informative, and I have been enlightened, and together with other participants, I'm sure this was a bit educative and mind-opening. And at this point, we just want to take a few questions that are in, or any other comment. If you feel you need to comment, kindly feel free to just raise your hand so that together we can be able to share and we can be able to learn together. So, Barasa, I'll pick a few questions and I'll read them so that maybe you can respond. But meanwhile, I want to receive all the accolades from our participants. Muita is saying very educative. Akoth Orwa saying great presentation. Patricia Mutiso, too educative, and many, many, many of you. Lydia Jeptum, nice presentation. So thank you so much, colleagues. And at this point, allow us to take in a few questions. If you feel you need to comment, you need to give an input, feel free to just raise your hand. I will be able to unmute you so that you can do that via the mic. So I will start with a question from Wilfred Aria. Is asking, some tumor markers like PSA don't come with the diluents in the kits. Do we have substitute diluents in the lab in such scenario? So thank you, Aria, for that. Cosmas, if you have any question, any remarks, but it's important to read the manufacturer's instructions. But over to you, Barasa.
Yeah, just as you've mentioned, it's important to read the manufacturer's instructions, and some of them don't come with those kind of diluents because they have given you an alternative. They'll maybe say you can use normal saline to do your dilution, but you have to confirm with the insert of the particular kit that you're using so that you can do the dilutions as necessary.
Thank you. Sebelina Kawira is asking, is it true that young productive mothers are at low risk of getting cervical cancer?
young, productive mothers.
Yes.
No, that one is not related to cervical cancer per se, because the only risk that is associated with cervical cancer is the multiple sexual exposures, which might now maybe give someone uh, multiple exposures to high risk HPV variants. That's the only thing that might influence the prevalence of cancer marker, the prostate, not prostate per se, cervical cancer in those ladies. So if she's active and she's maybe promiscuous and going around with so many people, that's a risk. But I'm not sure if it is a risk if it is just having many children from the same person. I think that's not a risk at all.
Thank you so much. I'll pick from Evelyn Awino. Can FNA specimen be used for identification of tumor markers?
Yes, the FNS specimens can be used for, because that's now cytology, it is called immunocytochemistry. If you have done your cytology exam and you have found that this is pointing to a certain particular tumor, you can do a cytochemistry on that particular slide and then determine your tumor markers and get a diagnosis.
Okay. So I'll read the next from Alfred Kipkurui. He's asking, does ANA positive test include tumor markers? And what are the normal ranges for ANA tests? That is anti-nuclear antibody.
Anti-nuclear antibodies are for autoinflammatory conditions. Those are not tumor markers. Those are inflammatory conditions, autoimmune inflammatory conditions. They are not tumor markers. They are other inflammatory conditions. So that is not completely applicable here, but it could be applicable in other inflammatory conditions, like maybe multiple sclerosis and those kinds of things, but not in cancer.
Great. So Ngeno Peter, I'll read your first question. He's saying, how would you differentiate whether an elevated tumor marker, e.g. PSA, CAA, beta ICG, is due to a malignant condition or a benign stroke physiological cause? What further test would you recommend?
Yeah, I mentioned that there are guidelines that help people arrive at a particular diagnosis. So you might not want to have one elevated PSA and conclude that this one is having a prostate, maybe prostatic cancer. You might want now to do a biopsy and now look at the cells themselves via histology or say histopathology, and then that can be able to point whether it's benign from the morphology of the cells and the tissue architecture, and then or malignant. From there, it can be able to point out whether it is actually that way. So you don't have to use a single modality. That's just an example. You don't have to use a single modality like maybe a tumor marker to particularly identify a cancer, but you'll have auxiliary tests, imaging, and physical exams, and you rule out so many things so that you can be able to remain with your diagnosis like that.
Thank you. I will read the next couple of questions. This is from Kezia Mungara. When a patient is declared cancer-free, are tumor markers involved? Okay. And then I'll read the other one from Peter Givigaro. Throat cancer. Which are the tumor markers that are used for diagnosis? Thank you, Peter.
Peter mentioned which cancer?
Peter is asking throat cancer, throat CA.
Throat cancer, throat CA.
Yes.
Yeah, it depends on where the cancer is. If it is on the lining of the epithelium, then there are markers for epithelial carcinomas. If it is maybe glandular, whether there is a gland in the throat, there are adenomatous markers, and also histopathology itself, looking at the particular morphology of that particular growth in itself. So it depends on where the cancer is and the morphology of that cancer, and now the individual markers that could be assessed depending on the kind of, if it is adeno, if it is glandular, or if it is, epithelial, or it's sarcomoid, or maybe affecting the muscles of the throat. Depends on which kind of cancer that you're dealing with. That one will guide on which markers to use. Yeah, there are markers to use on every cancer, but now it will depend on the morphological exam, which will point on specific markers that will be able to favor that kind of direction or thinking. Yeah.
Thank you. I will read from a question, more questions from, this is Joan Wabwile. Which tumor marker is used in Hodgkin's lymphoma after chemotherapy? And then I'll read the next one, which is from Vincent Ochieng. Which are the tumor markers for diagnosis of leukemia, prostate cancer, apart from PSA? Thank you, Vincent.
These are several questions. Maybe there's someone who asked about whether cancer-free patient can be declared based on the tumor markers. Yeah, we said that tumor markers can be used for prognostication, or maybe for prognosis of how a person is faring on, and the levels, serial levels, which are analyzed over time, can be able to help determine whether someone is cancer-free. Hodgkin's lymphoma, this one is, there is, of course, morphological determination of the presence of the SR cells, which is diagnostic in itself. But if you want to go further and do some, tumor markers, you might do the beta-2 microglobulin, which is also elevated in Hodgkin's lymphoma, apart from multiple myeloma. Then for leukemias, there are so many cluster of differentiation, CD markers for T lymphocytes and B lymphocytes, which can be able to help determine those kind of cancers. For myeloid cancers or myeloid leukemias, we can also use the BCR-ABL mutations or transcription genes. Then others also, the CD, the markers of CD for immature, the immature blood cells in different myeloid leukemias. So those can be used for different markers like that, and then arrive at a diagnostic. Prostate, apart from PSA and PAS, yeah, there are other guys. I think this one, there's someone who was working on the research, although it's not been, been released into clinical use. I think someone was looking at some molecule. I don't know whether it's there's a protein that I think maybe the colleague is here. It was Dr. Tyrus. I've forgotten the molecule. Who was looking at some prostate marker a while ago in histopathology. But maybe I'll be able to confirm the name of that marker later on. But you can also look at that. His research. He did some work on prostate, and there is a marker that he identified that could be used for diagnosis of prostate cancer, apart from PSA and the PAP.
Thank you. I want to ask whether this is, I can see that your hands raised, Felix Sagini, Ezekiel Mwenda, and Collins Wafula. So you can prepare your mic and ensure you have a quiet background so that I may unmute you and you just make your comments. So can I start with Felix Sagini? Felix, if you're in a position to speak, kindly unmute and make your comments. Felix? Felix Sagini? Okay. I'll go to Collins Wafula. If you can hear me, you can unmute and then you can talk. Collins Wafula, unmute kindly and proceed.
Okay, thank you. Good afternoon, all.
Good afternoon.
Good afternoon.
Okay, I would like to appreciate the presentation that has passed. by the experienced Daktari. And I know cancer is expensive in treating and managing. Okay, my question is, why don't we as a country or government try to put more energy or effort in maybe civic education to its people, maybe, and also to do more research for the doctors to do more research, of course, to enable them to do more research, to keep them that environment or to enabling environment, to do more research and specializing in the same, so that maybe we can detect this cancer before it reaches to maybe stage 2, 3, 4. Because when we detect it earlier, it will take us, it will give us good time to manage it. And also it will be cheap for us to do the same. So my question to our Apple people, our Apple leaders, why don't we put more energy in controlling, on trying to give education to our people, maybe to visit our facilities in as early as possible, so that we can detect as from the low facilities. Dr. said that we do maybe HPV. You see, it can be done as well as in the level 2 hospitals. So why don't we as a country put more effort so that we can manage this thing? I know it's a big giant because it's almost eating everybody. It's not that we don't know. It's not that we don't know. It is not painful. I know it's not painful. Sometimes you get it when it is in stage 2, 3, 4. So it has already worsened. But before it goes to that stage, why don't we educate our people to visit our facilities as early as possible? Thank you, Dr.
Thank you so much for your contribution. I think everyone who is here, he has heard. And Daktari, you have something to say?
Maybe just an input. I believe if there are people from the government who are in our midst, maybe they're hearing that. But it's a multidisciplinary approach. This one cannot be done by one person. Even now, this is just a motivation for us who are in the lab. You can also be out there and maybe help to produce this data, because in Kenya, the prevalence of cancer is not very, very well known because not so many people are being screened. But if you come out and maybe do some, your research, your own researches, and maybe as you're doing academic programs, or maybe on your own level as a person who is interested in maybe helping in the control of cancer, you can also decide to do a prevalence study on a particular cancer and help create this particular information. And these people usually make decisions based on information, right? So if they see that this is a particular cancer that has been determined by use of validated data that it is high in this particular region, then they can be able to put efforts there. Just like cervical cancer has been proved to be highly prevalent, and you've seen that there are vaccinations for HPV, high-risk HPV variants, and there are cervical cancer screening programs all over the place because it was shown that it is high in Kenya. So all the other cancers might follow the same kind of route, so that doctors or nurses or any other person might be able to come together and now determine the prevalence. The prevalence is not very much known. So I think that's where the gap is.
Thanks so much, Dr. I can see a few more questions and I think additions. Wilfred, I'll read your addition, and he's saying PSA is usually measured by immunoassays, e.g. ELISA, immunoassays. These assays are calibrated using human serum or serum-based diluents that closely mimic the patient sample matrix. Saline lacks proteins, lipids, and other serum components that stabilize PSA and maintain antibody binding efficiency. This can lead to altered antigen-antibody interactions, leading to underestimation or overestimation of PSA. The manufacturer validates the test using non-female serum naturally free of PSA as the diluent. So if saline is substituted, results will fall outside the validated conditions, making the test unreliable and not reproducible. Thank you, Wilfred, for the wonderful addition. And maybe I'll read a question. He's asking, how does hyperplasia... You can hear me?
Yes, we can hear you.
How does hyperplasia relate to age-associated enlargement of the prostate gland? In this context, when should PSA testing be preferred over prostatic acid phosphatase, that is PAP, in evaluation and management of prostate disorders? If you have anything. And then someone is asking, is cancer curable? Those two.
Oh, okay. PSA is more specific to prostatic, issues as compared to prostatic acid phosphatase. So in this case, I'll prefer the use of PSA either to screen for benign prostatic hyperplasia or the prostatic cancer. But for you to determine the difference, I think the core biopsies can be done to help you put those categories in their relevant group, whether it's benign or it is malignant. All right, and then if cancer is curable, cancer is manageable, and there are curative modalities right now, even for cervical cancer. We've seen that there is treatment for those cancers which are caught early, and people respond very well, and remission is not there. They come back to normal very fast. But for those guys who are having late cancers, that is the problem, because now there is metastasis and there is this cancer spreading to other organs, and it becomes complicated to treat. So it depends on the cancer level, the staging, and how early it's been caught. But there is treatment for cancer.
Thank you. There's an anonymous attendee who is asking, your slide on classifying tumor markers was very helpful, but I have a question about the tumor-associated antigens category. It includes items like viral antigens and oncogene products, which are direct tumor targets, but also inflammatory markers like ESR, which is a general test. Could you elaborate on the rationale for including ESR in that specific category rather than as a separate non-specific indicator? Over to you, Cosmas.
Well, I put ESR there because it's an unspecific inflammatory indicator which is present in many infectious and non-infectious conditions. This is not tied to a particular tumor. And viruses could be present and they could not be causing tumor. That's why they are associated with some cancers. Someone could have a high risk HPV and they don't have cervical cancer because there is no multiple exposures and everything like that. And maybe there is, the immunological control, because most of these viruses are cleared from the body immunologically. But when there is multiple exposures and the viral oncogenes now get integrated into the cellular mechanism of maybe, development and cell multiplication, that's where the problem becomes. So it is in that category because it's a gray area. Yeah, different viral oncogenes will be able to be applied in different kind of tumors, depending on the multiplicity of the exposures and everything. But for people who are having if you're having, maybe, for example, if I can be able to mention specifically for cervical cancer, because I know people are thinking of HPV and cervical cancer. If you do HPV, you can correlate with morphological HPV, DNA, HPV DNA. You can correlate with the morphological aspect of the cervical epithelium, and not all of them are usually having the cervical cancer. Yeah, but the presence of HPV will now help the doctors maybe target that particular virus and then treat it to help prevent the progression into cervical cancer. So it's a gray area, but it depends on how you're thinking about it.
Thank you. I'll read a case here from Ngeno Peter. He's saying, in our laboratory, we process samples for a 70-year-old male patient. His PSA came back at 14.2 nanogram per milliliter. Well, that is above the cutoff, which is 4. And CEA was 14.3 nanograms per milliliter, above the normal, less than 5. Both markers are elevated. Since PSA is mainly linked with prostate cancer, but can also rise in benign prostatic hyperplasia or prostatitis, and CAA is a marker for colorectal and other gastrointestinal cancers, but also elevated in benign conditions like smoking or inflammation. How should I interpret this simultaneous elevation in an elderly patient, and what further investigations would you recommend before a definitive diagnosis? I don't know whether you heard that.
Oh,
Doc?
yeah, I've heard it entirely. It's a very good thinking. I think people are now getting the entire thinking of this approach. So what you'll do, you'll help yourself by actually determining the clinical history of this patient, whether they have their physical exams, whether they're having any swellings or they are not, whether they're having difficulties in passing urine or they are not, because now that if they're having difficulties or maybe incontinence in passing urine, that will take you to the prostate, but away from the GIT. If they have had their endoscopy done, you can also be able to look at the report of endoscopy and help yourself. You correlate with other modalities so that you can be able to rule out as much as possible for you to indefinitely have this as a particular diagnosis, because you'll have those kinds of scenarios, but your elimination method is going to help arrive at a particular conclusion. So it might be a BPH, might be a prostate cancer, it might be a colorectal issue or a gastrointestinal issue, but your clinical history and other imaging modalities will be able to help in that particular condition, like that.
Very well, very well. That is quite clear. And maybe I can be reading a few more. And this is from, okay. Vincent Ocheng is asking, what are the tumor markers for diagnosis of breast CA? And then Ruth J. Lagat is saying, I know of someone who has been using betadine injection for a long time. So she has been injecting the same side every day until she forms a wound on the side. This wound has been treated but doesn't respond to any antibiotics. Can it be cancer? So over to you, Dr. Ari.
First of all, the markers for breast cancer are CA15-3 for circulating tumors, and maybe ER/PR for those guys who have done biopsies, and maybe HER2 as well, and others. But those are the most applicable cancer markers for breast cancer. Now, for that person with a wound which has had several injections, you might do a swab there, rule out the presence of microorganisms through a culture, and then maybe now start thinking of other things. But the most probable cause there could be an infectious organism, could be a bacteria and something like that. So you start with culture, and then maybe you can think about other things after you got that result for culture.
Thank you so much. I'll read another one from an anonymous attendee saying, if we still do histology and cytology, what's the relevance of having tumor markers? E.g., you determine epithelial, as you say, for throat. If cytology is being done, why again do tumor markers? Okay, thank you, anonymous attendee.
Okay. As I had mentioned in the presentation, there are guidelines guidelines on how to arrive at a diagnosis, which will start from the clinical presentation of the patient, the physical exam, and then the sample could be taken, whichever the sample. Say maybe a tissue has been taken now for histopathology. That tissue will first be processed and analyzed under the microscope to determine whether these cells are normal, whether they are benign, or whether they are cancerous. And this cancer will be able to favor a particular form of tumor. If it is epithelial, it will show a particular feature. If it is sarcoma, it will show a particular feature morphologically on the slide. If it is adenoid or maybe glandular cancers, it will show. And these ones, because you're dealing with a particular organ and you're dealing with a particular morphology, it will point on where to point or where to look at on the immunohistochemistry, the chemical markers now, the antigen, the cancer markers to use in that particular area. So you will not know the kind of tumor marker that you're supposed to use until you have looked at that slide, and then a further recommendation for auxiliary testing for those kinds of tumor markers now can come in IHC and other modalities like that.
Thank you so much. I want to confirm Abel Mageto and Ezekiel Mwenda, your hands are raised, and because we are winding up, I'll give you a minute each to make your comments and brief remarks. So I'll start with you, Abel. Abel, you can proceed to make your comments and mute. Okay, so if Abel is not responding, I'll go to the last participant here, who is Ezekiel Mwenda. You can unmute and make your comment. Ezekiel? All right, so if there's no further comments, I'm going to take this opportunity to thank all the participants for finding time to join in. And at this point, I'm going to take this back to the speaker to make his closing remarks. Thank you so much.
Okay, thank you so much for this time as well. And I believe that we have learned something. And as we go, let us embrace the practical approaches to cancer and help in its control in our communities. I think that's all from me. Back to you.
Thank you so much, Dr. for the wonderful presentation. Our participants have really enjoyed, and you can see their comments on the comment section. They are saying nice presentation. Some are saying we have learned a lot, and we want this opportunity to thank everyone who found time and joined into this call. I'm sure that this is an ongoing conversation, and we shall be able to do more of these trainings and webinars so that all of us can be capacity build in whatever place that you're practicing from, so that we can improve our practice, and also we can always share the best practices. And Matthew Simi is saying, great presentation, lab science is really the backbone. Thank you so much, everyone. And on behalf of LMSK, it was a pleasure hosting you, and be sure to tune in next webinar. Thank you so much, and enjoy.